lecture on Hodgkin's lymphoma, designed for use as either a tool for patient or professional education. Throughout this lecture, the disease will be explored in consideration of its pathogenesis, data surrounding the disease, risk factors, symptoms, prognosis, and treatment. As part of this educational tool, a case study will also be given to give a real-life point of view of the disease. As can be observed in Figure 1 on the screen, this is a medical image depicting Reed-Sternberg cells in the upper middle quadrant of the image. I will discuss these cells in detail throughout the lecture. Hodgkin's lymphoma, also known as Hodgkin's disease, is named after the practitioner who initially observed and defined the disease, Dr. Thomas Hodgkin. You can see him on the right of the screen there. Hodgkin's lymphoma is a cancer affecting a specific type of white blood cell known as lymphocytes, which mainly involves the lymphatic system observed in different parts of the body. It is also important to consider the classification of the disease, as there is known conditions classified as both Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma itself can also be subcategorised further. For the purpose of this educational tool, the main focus will be on classic Hodgkin's lymphoma, but I also will mention a few other subtypes as well. The data surrounding the disease outlines a few distinct trends in both the incidence and mortality of the condition. These trends are similar among both male and female genders, however slightly higher rates of the cancer can be observed in males. The diagnosis of the cancer typically either falls into the early 20s of the patient or after 60s. There are two different peaks of incidence and diagnosis. Between these ages, it is notably less common to be diagnosed. The Australian Institute of Health and Welfare outlines that in 2012, 338 men and 268 women were living with the disease in Australia. Similarly, mortality rates of 55 males and 23 females were observed in the same year. Due to the trends in both incidence and mortality, average age of onset is difficult to calculate. Both figures 3 and 4 depict these observable trends. In Figure 3, there is a distinct recession during middle age of diagnosis, as well as mortality being more common among the older population living with the condition. Figure 4 outlines that although diagnosis of the cancer has shown a steady increase over the past few decades, mortality has decreased. This can be attributed to more effective diagnosis and treatment as modern medicine has advanced. So in order to understand how the disease works, it is important to understand the lymphatic system as a whole and its purpose. The lymphatic system is part of the body's immune system and is sometimes referred to in literature as the sewerage system of the body. This is because it is a system of vessels that flow fluid called lymph around the body to specific tissues and nodes, with a primary role in fluid balance, collecting fluid that is drained into tissue from the bloodstream. The lymph nodes that are observed around certain points in the body, particularly around the armpits, neck, chest and groin, produce and release lymphocytes in response to pathogens and unusual cellular activity in the body. This accounts for swelling around the neck when a patient is ill. In Figure 5, I have highlighted specific points on the body that can be generally associated with the condition. These specific lymph nodes can be affected quite often. The pathogenesis of Hodgkin's lymphoma varies between subtypes of the disorder, but do share common mechanisms. As stated previously, the main focus of this lecture is on classic Hodgkin's lymphoma, but this mechanism can also be associated with nodular lymphocyte-predominant Hodgkin's lymphoma. The disease mainly involves the formation of Reed-Sternberg cells, referred to as HRS cells. And these cells are the malignant cells of the cancer and are derived from beta lymphocytes. They're larger than regular lymphocytes, can be multinucleated and invade the lymph nodes in which they can multiply utilising both NF-kappa beta and JAK-STAT proliferation pathways. In addition to HRS cells, the invading cells are also made up of inflammatory cells such as macrophages, which can contribute to the proliferation of disease and deposition of collagen fibre in the lymph nodes. And that's what is associated with the chronic swelling around the lymph nodes that we can observe in diagnosis of the disease. Figure 6 depicts HRS cells in the upper middle of the image. You can see those two there look a little bit different. The right HRS cell has become multinucleated, whereas the left one hasn't. In literature, these are sometimes referred to as owl eyes cells, which is not hard to imagine after observing this figure here. There are various complications that can result from Hodgkin's lymphoma. A major consideration for the disease is the prevalence of Epstein-Barr virus. Approximately 50% of patients that present with HRS cells will develop Epstein-Barr virus due to a genetic similarity between both the virus and a segment of genetic material associated with the disease. This may also be an inverse relationship, as patients who are infected with Epstein-Barr may be at a higher risk of developing Hodgkin's lymphoma in the future. Immunosuppression is also a consideration in patients with lymphoma due to the nature of the cancer itself. As the disease is targeting components of the immune system, the patient may be at a higher risk of infection and further cancers. A patient recovering from HL also must keep vaccination records up to date in order to prevent acquiring any preventable diseases such as measles and diphtheria. This may take a large amount of effort and monitoring on the patient's part in order to maintain these records and keep up to date. So it's not generally considered as a major complication, but it is something that needs to be considered with the patient's lifelong treatment. Inclusive of the patient's lifetime risk, it has been noted that a patient who has recovered from this condition will have an increased risk of further cancers in their life, particularly leukemia and further lymphoma. And in extreme cases, lymphoma can reoccur within 5 years of the initial cure. Lifelong cardiovascular and pulmonary disorder risk is also increased, and radiation and chemotherapy can also contribute to further immunosuppression and risk of infection and cancer in these patients. The risk factors of Hodgkin's lymphoma include extreme age, as previously outlined in these trends. You're either young or older, generally when you acquire the disease or are diagnosed. The male gender, infection with Epstein-Barr, genetic predisposition, mainly meaning having a first-degree relative that has the condition, even if they are a genetic mutation. And infection with HIV can also be a major risk factor. This figure displays Epstein-Barr virus, as I've already mentioned. The clinical presentation of Hodgkin's lymphoma doesn't have to present with symptoms. It may be asymptomatic and may only be diagnosed due to concurrent medical imaging that's occurring on a completely different or unrelated condition. Symptoms that may occur include chronic swelling around the lymph nodes, as I said, around the neck, groin, armpits and chest are where we can generally observe it most commonly. Excessive sweating, mainly at night, chronic fatigue, itching, shortness of breath, unexplained cough, unexplained weight loss of about 10%, and chronic ongoing fever of above 38 degrees with no apparent cause. Many of the symptoms may indicate later stage cancer, and prevalence of these symptoms can assist in classifying patients in their requisite stage of disease. So the diagnosis of the disease is mainly done, as I mentioned, by sign and symptom recognition. Following on from this, a biopsy can be done on the affected lymph nodes by removing part or all of that lymph node for analysis. This procedure will analyse cellular activity and identify any cancerous activity that may be present, and it also can assist with identifying what specific subtype of the disease the patient may have. Blood tests should also be done to assess the overall health of the patient and have a look at their blood count, which can help give us an idea of the severity of the disease. A biopsy of the bone marrow can also be completed to observe possible metastasizing of the cancer through the lymphatic system and into the bone. Medical imaging can also be completed to classify a patient by stage of disease and observe the spread of cancer. With regards to staging of the disease, the Ann Arbor system, which is this figure here, is one of the more commonly used classification tools for Hodgkin's lymphoma. It classifies them stages 1 through 4 based on the severity of the disease. So in the severity between stages is mainly inclusive of the region or how much the cancer is spread around the body. But each of these 4 stages is further classified into stage A or B. If a patient is classified as B, this means that the patient has at least one of these following observable symptoms, which is unexplained weight loss of at least 10% in 6 months, severe sweating, mainly at night as I mentioned, and a fever of at least 38 degrees with no other apparent cause such as infection. So the 5-year prognosis is determined by multiple factors. The severity of the cancer itself, patient's age, comorbidities and response to treatment. For localised Hodgkin's lymphoma, or stage 1, there is an observable 92% survival rate over 5 years. A similar rate has been observed in stage 2. Stage 1 and 2 is not is not a whole lot different with regards to the development of the cancer, so that's why we have a very similar survival rate. Distant and later stages still have a modest 5-year survival rate of 78%, which is accounted for by really good treatments that we have available for the disease. But these stages are more likely to induce lifelong complications for the patient. It is, however, difficult to estimate prognosis due to these dual trends of incidence, but is obviously, as we saw in the trends before, getting the disease earlier in life is associated with a better prognosis. As we saw, mortality rates were exponentially larger in older demographic patients who do get diagnosed with Hodgkin's lymphoma. Other generalised risk factors, such as being male and having an extreme blood profile during treatment, such as low hemoglobin, lymphocytes or albumin, can be associated with a poor prognosis as well. So treatment principles and the patient's regimen will be based on individual patient factors and done on a case-by-case manner. Age, overall health, symptoms, and their Ann Arbor classification of the disease will control what treatments are indicated for the patient. The various treatments that may be required to treat the disease include surgical procedures, radiotherapy, chemotherapy. Patients may have to have a stem cell transplant along with this, and then we also need to consider symptomatic relief of symptoms and signs and conditions that may come along with the cancer itself or from any of these treatments. So the surgical procedures for Hodgkin's lymphoma are mainly done in diagnosis. As I mentioned, biopsies are a large part of diagnosis. It's our gold standard. So this can be removing part or all of an affected tissue to prevent the cancer metastasizing or to just analyse what's going on to help diagnose it. The specific subtypes of biopsies that may be required include an incision biopsy, which is removing part of a lymph node for evaluating the tissue activity. A core biopsy, which is similar, but it uses a larger needle to extract a larger amount of that tissue. An excisional biopsy, which is removing the entire lymph node. This can also be done to prevent metastasizing as well as bone marrow aspiration, which is pictured here, which involves a needle inserted into either the iliac crest, the tibia, or the sternum to aspirate the bone marrow and assess the possible metastasizing of the disease. So radiotherapy is given, is one of the ways we can manage Hodgkin's lymphoma, generally after a period of chemotherapy for classic Hodgkin's lymphoma, as the chemo alone may not be effective. For other subtypes of the disease, including nodular lymphocyte predominant Hodgkin's lymphoma, radiation alone may be effective enough to treat the condition. The therapy itself utilises high-energy particle radiation to target these HRS cells and is referred to as external cell radiation. Therapy is usually given 5 days a week for multiple weeks. However, the procedure will generally only take a few minutes, but the procedure of setting up the equipment and making sure the patient is comfortable and in the correct position in order to target a specific part of the body can take quite a little bit more time. So potential short-term side effects of radiotherapy include skin conditions such as erythema and blistering, malaise, having a dry mouth, nausea and diarrhea, and other gastrointestinal symptoms that can come quite immediately. Longer-term effects include hypothyroidism, slowed bone growth, particularly in children, having an increased risk of cardiovascular and pulmonary disease, as I mentioned previously, and infertility can occur with radiotherapy as well. So there are specific subtypes of this radiation therapy that target different sizes and different areas of the body. This is done in order to target specific lymph nodes that are affected by the disease, the region of the body, or the entire body of the patient in later stage disease. This is obviously relevant to the severity of the lymphoma itself. These include ISRT, which is involved site radiation therapy, IFRT, which is involved field radiation therapy, EFRT, which is extended field radiation therapy, and total body irradiation. Chemotherapy is another thing that we can use to treat the Hodgkin's lymphoma. It involves using cytotoxic drugs given either intravenously or as an oral medication to target and kill cancer cells. Cytotoxic agents are toxic to cells and are given as combination therapy to target multiple parts of the cancer proliferation pathway. The nomenclature used to classify chemotherapy is defined on an acronym basis, with each letter corresponding to a particular drug in the treatment regimen. Common treatments include ABVD and BEA-COPP. So ABVD is first-line option for treating classic Hodgkin's lymphoma. Involves doxorubicin, vinblastine, bleomycin, and dacarbazine. Each drug is able to target a specific part of the cancer pathway to optimise the treatment for the patient. As I said, BCOP is also another common regimen. Similarly, includes a few different drugs. There are some other regimens as well that can be indicated if the patient's having a high amount of side effects. But there are literally hundreds of different combinations that we can use in chemotherapy, and it's generally done on a case-by-case basis, assessing their response to treatment. So a stem cell transplant can be indicated for a patient if the cancer is not responsive to chemotherapy, or if they are having some extreme blood profile counts during their treatment. Figure 9 on the screen, this one here, goes through a few of the different steps involved in an autologous stem cell transplant, which involves taking the patient's individual own stem cells, processing them, and then giving them back to the patient after a round of chemotherapy when their blood's down in order to stimulate new cell growth. So it involves getting the stem cells mobilised with drugs, collecting them, and then processing them, and then once required, we can reinfuse them into the patient to begin producing new cells. These stem cells can also be collected from a first-degree relative as a donor. There are some side effects to this treatment, including myalgia and tingling, which is mainly secondary to hypocalcemia. IV supplementation may be given if this does occur. So immunotherapy can also be considered if required. Brentuximab, rituximab, nivolumab, and pembrolizumab, monoclonal antibody drugs used as immunotherapy, which is utilising the body's own immune system to fight the cancer cells. They may be combined with radio or chemotherapy to maximise positive outcomes for the patient. Certain conditions can come secondary to either Hodgkin's lymphoma or the specific treatments which need to be considered for optimising the quality of life for the patient. Antidepressants and anti-nausea therapies may be indicated if required to manage a few of these symptoms. It also, as I mentioned, it's important to consider the side effects of chemotherapy and other treatments, mainly including mouth and throat sores, fatigue, pain, and gastrointestinal disturbances, so we can manage those individually if need be. Now moving on to our case study for this presentation, we have a patient named Alana who has experienced firsthand what living with lymphoma is like. These details are based on an interview I had with the patient over the phone, and consent was gathered to utilise her specific details of the story for this presentation. Alana is also my twin sister, so I have quite a close relationship with her and quite a heavy knowledge of what went on during her management of the disease. This is very much a classic case of Hodgkin's lymphoma, but it is important to consider not just the treatment and the outcomes observed, but the real life impact that it had on the patient. She was 16 at the time of diagnosis, a full-time high school student and working part-time in a local community pharmacy. She was diagnosed only when she asked a pharmacist at work, what's this on my neck, basically, and he then referred her to her GP, and it all snowballed from there. Her presenting symptoms at the time that she didn't quite pick up on were fatigue, night sweats, and some itching as well. The patient was given 12 rounds of ABVD chemotherapy as she was classified as stage 2A of the disease. She also experienced neutropenia due to her neutropenia in her therapy due to the drugs that she was using. The main impact that the disease had on the patient were on day-to-day life, social and emotional impacts. she wasn't able to spend time with her friends throughout the treatment. She had to leave school, and that upset her quite a bit. She also lost her hair, which at the time before diagnosis she had really long hair down to her hips, so that had quite a profound emotional effect on the patient as well. Since then, however, she has made full recovery. She has completed a Bachelor's of Nursing with UOW and is currently studying a graduate diploma of midwifery. So she's in the health industry too, which is great to see. The limitations of the overall management of Hodgkin's lymphoma occur mainly in the diagnosis and follow-up consultations associated with the disease. Diagnosis is mainly done initially by signs and symptom recognition. As I said, these generally only start to come about later on with the development of the disease anyway, which generally means the patient will be in the B classification for their requisite stage of disease. This can lead to poorer patient outcomes, and HL is generally cured quite quickly and yields a high percentage of patients making full recovery. Post-remission, the patient is required to have extensive follow-ups every couple of months and then less and less often as time goes on. But maintaining these consultations can be difficult with a patient once they're cured, as compliance starts to become an issue as well. For the future development of managing Hodgkin's lymphoma, there is a heavy research emphasis on the use of specific biomarkers to monitor the disease, response-adapted therapy and immunotherapy with monoclonal antibodies, as I mentioned. In addition to this, PET scanning does have a defined role in diagnosis and staging of the condition. A current barrier with this is the cost associated with doing a PET scan. It costs the government $5,000 to $7,000 if it's done at public hospitals. But there is some recent research outlining the role of PET scanning as critical in staging patients, which in turn obviously leads to more accurate treatment and positive patient outcomes. Thank you very much.